So first of all, thank you very much to AFRAN and to the ISN for this wonderful privilege of being able to come today and speak and to listen and to learn at this fantastic meeting. I just wanted to start off this talk on ethics with two brief stories. The first actually comes from India, and if you're interested, it's actually been published recently, and I think it's an open access paper. It's one of our colleagues from the ISN, Arpana Iyengar from Bangalore, who wrote this case up, and I thought was quite brave. He describes a 3-year-old boy who was diagnosed with quite severe nephrotic syndrome, and then by the time he was 11, he needed to get onto dialysis. This involved a lot of discussion with the mother because the family was extremely poor. And then, unfortunately, nobody in the family was healthy enough to be able to become a living donor, so this child had to be put on the deceased donor list. There was a kidney available at age 18. This was, again, another big decision point for the family. And unfortunately, after 1 week, this child developed severe antibody-mediated rejection and actually lost the kidney despite enormous amounts of treatment that they tried to rescue the kidney. So he landed up back on dialysis. So this really just illustrates two things. The first was the doctor's dilemma. She knew that this family was very poor, but she also, as the physician for this child, needed to try to offer him the best possible care. So she was struggling with this idea, do I tell them about dialysis? Do I tell them about transplantation, knowing that this would probably put an enormous strain on the entire family? And then on the other side, the mother, obviously loving her child, wanted to do the best for her child, and she landed up having to work 7 days a week to try to come up every week with money for dialysis. And I think this is something you're all very, very familiar with. So then when this option of a kidney transplant came up, initially the mother was very afraid and said, I don't have the money. And the doctor encouraged her enormously. She was able to scrounge money, I'm guessing within 24 hours, paid for this kidney. But then obviously when the kidney was lost after a week, the mother was very sad and desperate and feeling she'd spent everything for nothing. And basically in the discussion of this paper, Arpana basically puts this forward as saying, did I do more harm than good in trying to advocate for this young boy's life and to advocate for the best treatment? And then on the other side, this is actually a story that came up in a paper. It's an American paper that's discussing rationing and struggling how to allocate resources. And this person essentially gives the analogy. It was a very, very busy emergency room doctor who said he feels like sometimes he's this rescuing person who's constantly dragging people floating past very fast in a river, pulling them out and trying to resuscitate them. And he's actually so busy doing this that he never can stop and ask himself, why are there so many people falling into this river? What's going on upriver? Why were these people not taught how to swim? And also, why do they not have any life jackets? And this for me is quite a good analogy for end-stage kidney disease, because we know that if we prevented people from falling in the river in the first place, we would be preventing kidney disease with public health measures. If we wanted to teach them how to swim, we would have at least universal health coverage and access to primary care where they can have prevention once, or at least secondary prevention once they develop risk factors. And then finally, when they're rushing past in this river, it's the usual crash landings that we see with end-stage kidney disease. In other settings, there is equitable access to kidney care, and it's less of a desperate situation. So the question really is, how and by whom should this problem be fixed? And in these two different scenarios, I'm just trying to show you the clinical place where ethics comes in, and also the public health and health system place where ethics comes in. And just myself, having learned about ethics in the last couple of years a little bit, and I think we all are people who know ethics. We all have ethics inside us. It's not that anyone is more ethical than another, but what I've really learned is just in trying to distill these problems, thinking about them in terms of ethical principles, it's helping me to grapple with ethical issues myself at the bedside, and also to try to develop tools that are rational and objective that can be used for advocacy, as we've heard these wonderful pleas this morning from all the speakers. So just very briefly, what I would like to just make people aware is that there are biomedical ethics that we're all quite familiar with, but there's also this field of public health ethics that we as nephrologists specifically, potentially even more than other specialties, because we're dealing with such expensive care, have to be aware of. And then again, in 20 minutes, I cannot discuss this in detail, but just under ethics, we'll go a little bit more into what Gloria Ashintantang touched on, this moral distress, and then a little bit more into priority setting, which Professor Jha also touched on. And just one big message in ethics There's no specific right or wrong, unfortunately, because then everything would be easy. We usually have to find somewhere along the spectrum of right or wrong where we ourselves can hopefully feel comfortable and we reach the best compromise. So just very briefly, to go through biomedical ethics and public health ethics. Biomedical ethics is what we're all familiar with, that we do every day. And I've just highlighted various things that are relevant specifically to end-stage kidney disease, such as informed consent, patient advocacy, and then this use of emerging technologies and sometimes bedside rationing. Occasionally we have 2 patients who need urgent dialysis and only 1 machine, and so we at the bedside have to try to decide who of these 2 people do I dialyze. And then in terms of public health, the health system in general has to concern itself with vulnerable populations and the uninsured. How do they get access to care? The social determinants of health are extremely important in why people are getting sick, so poverty, gender equity, access to education, etc. And then cost effectiveness needs to come into the picture. So in biomedical ethics, we have the usual 4 principles: autonomy, beneficence or doing good, non-maleficence or doing no harm, and then justice and fairness. Interestingly, autonomy in this particular paper is in bold. It's a Western, North American or European perspective where the patient's own decision is the main ethical principle that everybody tries to follow. But in other communities where decisions are made by families, or sometimes, for example, trying to explain to someone that dialysis and transplant are available when you know that it's just not available in your particular center, for example, some people argue you're respecting the patient's autonomy by telling them somewhere in the world you might be able to be dialyzed, but some of us really feel that in that case the patient has no choice, and when a patient has no choice, you can't respect their autonomy. And then in public health, the health system needs to think about population level utility, which means trying to maximize general population health, and very often here, very cheap, high quantity things like vaccinations, for example, will take precedence over intensive care or dialysis. Should be based on evidence. Justice and fairness is important to try to understand, are we being fair as much as possible to everybody? Governments need to be accountable for their decisions. Cost obviously needs to be considered. And then the individual, the principles that apply to the individual, like beneficence, non-maleficence, and autonomy, take a little bit of a back seat when you're thinking purely about public health ethics. But you can imagine that how to balance the benefits of the population versus the individual is not always easy. And so essentially ethical dilemmas arise when there are conflicts between the principles, and we have to try to find somewhere along this line where we can settle. And yesterday there was a fantastic talk on ethics and transplantation by Dr. Matthew Koech, who's hopefully here somewhere, and I asked him, I took a picture of the slide, and I thought the slide illustrates very well the tensions. Just as an example, a patient on dialysis needed a kidney, and the family had gotten together and identified a certain relative who was less well-to-do, who was going to become the donor. And so the physician then has the dilemma. For this particular donor, who is poorer than the rest of the family, is donating potentially going to be harmful to him, or is it even going to be beneficial to him? The question is, would the benefit potentially be some form of a payment, in which case you have to ask yourself, is this donor being coerced into donating, or is he truly giving free consent? Is he exercising free will? And then, is this being done in the patient's best interest? What are the doctor's motivations in terms of pushing for the transplantation, etc.? So this case really illustrated very well the tensions between a lot of these ethical principles that we have to deal with every day. So now just to focus in a little bit, going back to ethics in clinical end-stage kidney disease care. So you've actually seen this data from both earlier speakers. I'm not going to speak on this very long, but we just heard that about 1% of newly started, usually crash-landing dialysis patients in sub-Saharan Africa are alive after 1 year. But the flip side in this systematic review was actually that of the prevalent patients, so people who were able to remain on dialysis for longer than 3 months, in general, 83% of them were still alive at 12 months. So this really shows the money part, because what's different between the incidence and prevalent patients is the prevalence were just able to continue to pay out of pocket, or were from Sudan or South Africa, where those cohorts were actually being provided dialysis by the government. Two other important other problems that are often ethical dilemmas for the treating team is that many patients are lost to follow-up, and what do we do about that? And then also 20% of the children included left against medical advice, disappeared in the middle of the night. And one can just imagine the immense humiliation of the family receiving advice about how to look after their child and then knowing they cannot follow that advice and essentially just disappearing from the hospital. So this essentially, as Gloria mentioned, creates a situation of moral distress, which by definition is when you know the right course of action, but because of circumstances you cannot carry this out. And this is happening everywhere to physicians in most places, but obviously in resource-limited settings is a lot more acute and the stakes are often a lot higher. So again, going back to the survey that some of you might have very generously answered at the last AFRAN and Kenya Renal Association meeting, we tried to understand, are nephrologists experiencing moral distress? And as you can see, around 40% of people within the last 2 years have had to themselves make a choice of restricting dialysis from one patient to benefit another. This is a dilemma that almost never happens to people practicing under universal healthcare systems where dialysis is universally accessible. About 40% of people brought in considerations about what is this payment for dialysis going to do to the family. And about a quarter of people had this tension between how can they balance their public and their private hospital responsibilities. What was positive was that around 75%, sorry, I'm not sure where I'm supposed to point this. So around 75% of people did feel they were working in an environment where they could discuss ethical dilemmas with colleagues, and this is extremely important. But interestingly, about 3/4 of people reported that they frequently worry about patients not being able to pay when they're off work, so they're at home. So these are things that are disturbing doctors morally. And so and moral distress is prevalent amongst the nephrologists. Then a paper from Nigeria, and Fatu Aragundare was one of the authors here, looked at the burden of care amongst nurses. And here you can see that 60% of the nurses caring for renal patients, dialysis patients, experienced burden. And they had a long list of what were all the causes, and these were all at least about 50-55% of the nurses reported these, and mostly were due to lack of either resources in the center or patient resources. And then families also experience significant moral distress. So this is actually a study from Ethiopia. It's not about kidney disease, but it was a study where someone did their PhD asking families when they had a sick neonate at home, why did they not access care? It's a bit complicated, but she eventually tried to distill all the different components of how families actually make a decision. And in the red box in the middle, families obviously first need to decide, do I try to seek care? And they always know money is involved. Do they spend the resources? And the third thing is, do they follow medical advice? And unfortunately, this then often leads to a lot of adaptations on the side of the family, but also adaptations on the side of the treating team who try to adapt whatever they can deliver within the patient's resources. But this again causes a lot of moral distress also for the families. So doctors, nurses, families, everybody is experiencing moral distress related to this lack of access to care. So now switching gears a little bit to public health and end-stage kidney disease, just briefly to give you an idea, the difference between equality and equity. Equality means that everybody gets the same thing. We're distributing resources equally to everybody. So for example, at the moment, we all want universal health coverage. Most of this universal health coverage is a basic package of services that very often does not include dialysis. So you can imagine the basic package of services as being the small box under all the children on the left-hand side. Each person gets exactly the same box. As you can see, some people are big enough, they don't even need really the box. Other people can maybe, this box helps them to just get by, but then there are other people who this box is of no use at all because their needs are totally different. So the ideal is actually the picture on the right-hand side, which would be to achieve equity, meaning to try to allow everybody the same opportunity, and because of what people's needs are, they may be different, to try to meet those needs in different ways to create these equal opportunities. And this would be an ideal health system that tries to maintain everybody living the healthiest possible lives that they can live. But obviously people with kidney disease would need a lot more resources than somebody who has a sore throat. So this unfortunately involves priority setting, because in any country in the world there isn't really enough money to meet every single need. And so priority setting essentially means that trade-offs have to be made about what kind of services should be provided and to whom. And this means withholding some services from individuals or groups that could benefit from them, knowing that you're not providing this treatment. So this is an example, and the Kenyans here might be very well aware of this. This was published in 2014. It's a document that was published from the WHO. But interestingly here, they made recommendations to countries basically only on cost effectiveness. So they really only thought, how much money can we spend and how many lives can we save? In lower income countries, the cost effectiveness threshold to be very cost effective is something that costs less than 1 GDP per person. So for example here, the diagnosis and treatment of tuberculosis or introducing traffic safety regulations like wearing helmets costs less than 1 GDP per person, and therefore this should be always covered in every country. When you start thinking about treating asthma, this gets to the point of 1.5 times the GDP. Sorry, my animated slides are slowing me down here. So asthma would be 1.5 times the GDP, and so the suggestion of the authors in this manuscript are, once you've covered all the people with TB and everybody's wearing a helmet on their motorbikes, then you can start thinking about treating asthma, which seems absurd because obviously treating a child with asthma sounds like something quite easy and you should be doing. But then they actually used the Kenyan data and looked at Kenya and said dialysis would cost 30 times the GDP, meaning for each one dialysis patient you could treat 300 people with TB. So they essentially said Kenya should not consider implementing universal dialysis. Thankfully, as we heard last night at the opening ceremony, Kenya decided not to follow these recommendations, and it appears that there is fantastic progress happening here because of the government commitment. And this government has obviously decided dialysis is expensive, but for some reason they've decided it's worthwhile. And one of those reasons might be, and as Dr. Jha mentioned as well, one of the cornerstones of universal health coverage is protecting people against financial hardship. And this is exactly what dialysis does when you have to pay out of pocket enormous amounts of catastrophic health expenditure. And this was just a survey that the Thai did before they decided to introduce dialysis under universal health coverage. They put a very cost-effective case of laparoscopic cholecystectomy versus the expensive case of dialysis to multiple different people. And as you can see, that despite the fact that the costs were very high, which is on the extreme right-hand side, everybody, or most people in fact, chose dialysis should be prioritized over laparoscopic cholecystectomy. And when they were asked this, they said because it saves lives. And so here also there's the human compassion side. You can't only think about cost effectiveness. But there are enormous amount of stakeholders, and I think that's come up in the two talks this morning. As Gloria mentioned, industry, I think, also has a very big role to play. If markups are excessive, we have to find a way to reduce prices to make dialysis more accessible. Kidney organizations like the ISN are important for advocacy, for example, like AFRAN. We heard yesterday the Kenya Renal Association has played a huge role in raising awareness in the government and achieving the successes. NGOs often come in vertical programs, and as Gloria mentioned, donations do not work, and also these little vertical programs where you try to provide dialysis to a few select people independently of the integration into the health system, that also doesn't work. But as you can see, there are an enormous amount of stakeholders, and each one of these has also ethical obligations to make sure they collaborate, they are humble, they are transparent, they are accountable, and they all work together with this common goal of trying to improve access to care. So then, just in summary, the ethics of end-stage kidney disease is actually quite complicated, and again, I'm just giving you a tiny little idea. So if we go through the principle of benefit versus harm, very often here we are trying to decide, exactly as Gloria said, between life and abject poverty. If a family pays out of pocket, the person might stay alive, but if that person stays alive, the children then don't go to school, or who knows what else happens. So health is also extremely a critical issue. Then we have respect for autonomy. So here, dignity and suffering, as I mentioned, sometimes some ethicists believe you should tell patients about every single option, but if that option is not available, is this really just causing more distress and causing more humiliation than actually respecting their autonomy? And suffering is key, and as we heard also from both talks, if we cannot provide end-stage kidney disease dialysis or transplantation, we need to relieve suffering as one of our highest common goals. Then social justice is key as well. We mentioned the struggles, the dilemma between trying to meet the needs of the individual, especially if they need expensive care, versus meeting the needs of society as a whole and trying to save as many lives as possible. And then transparency and accountability are critical values, especially from the public health system, because the population needs to trust that the stewards of the health system, the government, the Ministry of Health, the Ministry of Finance, are actually trying very honestly, carefully, equitably to distribute the resources in a way as fair as possible. But if it's not possible to, let's say, provide dialysis for everybody, the government needs to be accountable for that and needs to try to commit to a progress where they may be able to eventually achieve that. The other big issue in terms of transparency is conflicts of interest, and we've heard that companies may have enormous conflicts of interest. Individual doctors, patients, families, donors, recipients might have conflicts of interest, and even countries, because dialysis is a little bit of a badge of honor when a country can say, yes, we have dialysis, without necessarily saying who can actually get dialysis. So these ethical dilemmas, unfortunately, are rampant and everywhere. So just in conclusion, I think nephrology clinicians in resource-constrained settings are often trapped between trying to maximize benefit for the individual and considering the impact on the family and the society. What I feel is ethics knowledge may help us in trying to analyze the dilemma, to try to facilitate discussion amongst ourselves and provide peer support to people who are going through dilemmas, and also helping us to take difficult decisions at the bedside transparently. And then the status quo, as we keep hearing, is highly, highly inequitable. And we need to try to engage all stakeholders to find sustainable and fair solutions for patients with end-stage kidney disease. Thank you.